All right, let's truly unpack this. Today, we're embarking on a deep dive into a world that, despite its microscopic scale, plays a colossal role in our health. It's a realm of master strategists that thrive where oxygen is scarce. We're talking about infections due to mixed anaerobic organisms.
So,
Our mission, to take a treasure trove of insights from foundational medical texts, specifically Chapter 177, and really arm you with the kind of in-depth, actionable knowledge that the elite professionals carry. Get ready for some serious aha moments as we transform, what might seem like complex concepts into crystal clear understanding.
indeed. We're going to journey through their ancient discovery, explore their critical roles as our silent partners, and then crucially delve into how to recognize, diagnose, and really master the treatment of the unique infections they cause. It's a fascinating exploration of the unseen, but one with immense real-world implications for understanding a significant slice of human health and disease.
Okay, to truly grasp the significance of anaerobes, we have to rewind the clock. Way back. Imagine stumbling upon life thriving in conditions you never thought possible, centuries before we even truly understood oxygen. That's precisely what happened in 1680. What did Antony van Leeuwenhoek uncover, and why was his, seemingly simple observation so revolutionary?
Right. What's truly fascinating here is Leeuwenhoek's almost accidental discovery. It inadvertently laid the foundational principles of anaerobic life. He prepared this simple culture medium, crushed pepper and rainwater, then divided into two glass tubes. One he left open, the other he carefully sealed. After several days, he was surprised, really surprised, to find his animalcules, his term for microorganisms, in both tubes.
In both, even the sealed one.
Exactly. But what really caught his eye, and he was meticulous, was his note that the bacteria in the sealed tube were bigger than the biggest sort he'd seen in the open one. This was remarkable. I mean, this was nearly a century before oxygen was formally characterized. So this observation, later confirmed by Pasteur, established that an anaerobic environment, often created in a closed space as aerobic organisms consume oxygen, leads to the outgrowth of these oxygen-averse anaerobes. It's a core concept, still defines our approach today.
So these are organisms that don't need oxygen, but it's not just a simple on-off switch, is it? There's more nuance?
Oh, absolutely. Their relationship with oxygen is quite nuanced. We categorize them based on their precise oxygen requirements or maybe tolerance levels. First, you have obligate anaerobes. These are extremely sensitive, killed by even minimal oxygen, like 0.5% or more.
Really
Right.
sensitive.
Very. Then there are aerotolerant organisms. These guys can withstand oxygen. They won't die immediately, but they can't actually use it for growth or energy. Most of the clinically relevant ones, Bacteroides fragilis, Prevotella melanogenica, Fusobacterium nucleanum, they fall here.
Okay, so they tolerate it but don't use it.
Correct. And finally, facultative anaerobes. These are the most versatile. They can grow both with and without oxygen.
The adaptable ones.
Exactly. And this varied tolerance, it largely depends on whether they express specific protective enzymes. See, molecular oxygen, when it reacts, it can form highly damaging byproducts like superoxide radicals and hydrogen peroxide. Aerobic organisms, and even these aerotolerant anaerobes, possess enzymes like superoxide dismutase and catalase.
Right, the cleanup crew.
Precisely. Superoxide dismutase converts the harmful superoxide into less harmful hydrogen peroxide and oxygen, and then catalase breaks down the hydrogen peroxide into water and oxygen. The amount of these enzymes an anaerobe produces directly dictates its ability to handle oxygen's toxic effects. It's a neat biochemical adaptation.
And their energy production. That's fundamentally different from ours too, isn't it? For us, it's all about oxygen, but for them...
It's a whole other ballgame, yes.
Yeah.
A stark contrast. In aerobic respiration, which we use, oxygen is the final electron acceptor in a highly efficient chain, generating tons of ATP, the cell's energy currency.
Right.
Anaerobes, lacking oxygen or the machinery to use it, employ alternatives. They can get energy via either anaerobic respiration or fermentation.
Mm.
In anaerobic respiration, they still set up an electrochemical gradient, but instead of oxygen, less oxidizing molecules act as electron acceptors. Think sulfate, nitrate, CO2, fumarate. This pathway is less efficient than aerobic respiration, produces less ATP.
Less efficient, okay.
Then there's fermentation, even more rudimentary, even less efficient. Doesn't use an electrochemical gradient. It just directly releases energy from organic molecules like pyruvate. To give you an idea, fermentation yields only about 5% of the energy aerobic respiration gets from the same amount of glucose.
Wow, only 5%.
Yes, and this huge energy difference explains why facultative anaerobes will always choose oxygen if it's available. It's just far more efficient. When oxygen is scarce, they switch to anaerobic respiration, or if that's not possible, they resort to fermentation. remarkable metabolic flexibility.
It's so easy to label bacteria as good or bad, but anaerobes really show the complexity, don't they? Most of them are actually our silent partners, making up the vast majority of our normal microbiota. What are the sheer numbers we're talking about, and where do these communities mainly thrive?
The numbers are, well, they're truly astounding. They highlight our deep coexistence. Anaerobes utterly dominate human mucocutaneous surfaces, the linings of our body cavities, our skin, often accounting for 99.099.9% of the cultivable microbiota there.
99%.
Yes. To put that in perspective, concentrations range from about 103 per ml in the nose to a staggering 10-12 per ml in places like gingival scrapings, the stuff around your gums and the colon.
10 to the power of 12, that's a trillion per milliliter.
That's right, a trillion. And it's fascinating they inhabit areas technically exposed to air, like skin, nose, mouth, throat. Seems contradictory, right? But they thrive in specific protected niches. Think deep gingival crevices, oxygen-poor spots. And crucially, local anaerobic environments are often created by neighboring aerobic organisms. They consume the oxygen, lower the potential, allowing the anaerobes to flourish.
So the aerobes actually help them out.
In a way, yes, by modifying the environment.
Yeah.
And our understanding has exploded thanks to things like the Human Microbiome Project. We know of over 10,000 bacterial species in the collective human microbiota, over 1,000 in the gut alone. The vast majority are these beneficial partners.
Okay, given those incredible numbers, can you give us a snapshot of the key players and their usual hangouts, like who's living where?
Certainly. Knowing the addresses is key. The primary reservoir, no question, is the lower gastrointestinal tract, cecum, colon. Here, bacteroidetes and firmicutes are predominant. Huge numbers of Prevotella and Bacteroid species. The B. fragilis group, including B. fragilis itself, B. the T-tiotic omicron, others, is especially prominent. You also find Clostridium, Peptostreptococcus, Fusobacterium. In the colon, the anaerobe to aerobe ratio can hit 1,000.1. Concentrations up to ever 11, then 10-12 per ml.
1,001.
Yes. Moving up, the oral cavity is another major hub. Prevotella and Porphyromonas are big players there. Fusobacterium, non-B fragilis bacteroids too. Think F. nucleatum, P. melanogenica. The female genital tract also has a considerable population, maybe 10.1 anaerobes to aerobes. Prevotella, bacteroids, Fusobacterium, Clostridium, and finally the skin, ratio around 100.1. Cutibacterium acnes, what we used to call Propionibacterium acnes, is the main one there. They're truly everywhere in specific niches.
Okay, here's where it gets really interesting for me. They're so common. What essential jobs do they do for our health? It's got to be more than just existing, right?
You've hit on a critical point. Their roles are indispensable. Our health literally hinges on these silent partners, especially the anaerobic intestinal microbiota. They mediate a huge range of physiologic, metabolic, immunologic functions. One huge metabolic job is fermenting dietary carbohydrates. We eat complex polysaccharides our own enzymes can't touch. The microbiota ferments these into usable energy for us. Bacteroid species are amazing at this. They have the widest array of polysaccharide-degrading enzymes. The Tiote omicron, for instance, have 172 different glycosyl hydrolases.
172, just for breaking down sugar.
Exactly. Provides vital nutrients for us and other gut bugs. Beyond energy, they produce crucial secreted products, like vitamin K for blood clotting, bone health, bile acids for fat absorption, cholesterol regulation, and perhaps one of their most vital functions, colonization resistance.
Ah, yes, keeping the bad guys out.
Precisely. They interfere with pathogenic bacteria, they consume oxygen and nutrients, produce enzymes, toxic end products, and they modulate our innate immune response. They're critical in defending us against serious gut infections like Salmonella and the notorious Clostridium difficile. It's like a living shield.
Beyond just fighting invaders, they also seem to regulate our immune system. That sounds huge. How does that work?
Precisely. This is one of the most exciting areas. The profound immunomodulatory properties of the gut anaerobes. It's not passive defense. They actively educate and regulate our immune system. The classic example, the one that really opened doors, involves Bacteroides fragilis. It is a unique surface molecule, polysaccharide A, or PSA. Researchers found B. fragilis, via PSA, can significantly balance T cell functions. More specifically, it can induce colonic regulatory T cells, TREGs.
TREGs, the ones that calm the immune system down.
Exactly. They suppress excessive immune responses, maintain tolerance, prevent autoimmunity. PSA does this by stimulating macrophages via toll-like receptor 2. And B. fragilis also has another molecule, a glycosphingolipid, that regulates other immune cells called invariant natural killer T cells. We now have loads of examples of other commensals modulating immunity, influencing T cells, dendritic cells, antimicrobial peptides, both in the gut and beyond.
So it affects the whole body's immune system.
Yes, which means when this delicate balance is disrupted dysbiosis, it can significantly contribute to diseases involving chronic inflammation and weird immune responses. We see increasingly strong links to inflammatory bowel disease, IBD, rheumatoid arthritis, multiple sclerosis, asthma, type 1 diabetes, and beyond autoimmunity, also metabolic disorders like obesity and metabolic syndrome. It truly shows how critical this balance is, far beyond just gut health. It's systemic, a complete game changer in how we view disease.
So, okay, most are beneficial, but sometimes that harmony breaks down. How do these infections actually start? And what makes them so unique in terms of the bacteria involved?
You've nailed the core issue. Anaerobic infections fundamentally happen when the normal microbiota, usually stuck in our mucous membranes, gets introduced into normally sterile tissue. This typically happens through a disruption of those mucosal barriers.
Yeah.
Think a perforated intestine, a deep bite wound, significant trauma. Anything that breaches the natural defenses.
It's an opening.
Exactly. A pathway for them to leave their normal home and enter a sterile place where they can cause trouble. And what makes these infections unique is, because those colonized sites, gut, mouth, skin, harbor so many species, the resulting infections are almost always polymicrobial. You're dealing with a complex mix, not just anaerobes, but often anaerobes acting synergistically with facultative and/or microaerophilic organisms. It's a bacterial team effort. Makes them much harder to deal with.
Right, a game working together. Despite thousands of species, you said only a few genera commonly cause infections. Does the infection site give us a big clue which ones we'll find?
Absolutely. A critical principle for clinicians. The specific bacteria causing the infection usually mirror the normal microbiota of the neighboring anatomical site. Makes perfect sense, right? They got displaced from nearby. So if you have a head or neck infection, you strongly suspect organisms from the oro- and nasopharyngeal microbiota, like Prevotella melanogenica, various Fusobacterium, Peptostreptococcus, Actinomyces. They cause odontogenic infections, peripharyngeal space infections, chronic sinusitis, even pleuropulmonary infections if aspirated.
Following the source.
Precisely. Similarly, in female genital tract infections, you commonly find vaginal colonizers like Prevotella bivia and P. diciens. And for intra-abdominal abscesses, the usual suspects are E. coli and members of the B. fragilis group, both major players in the gut microbiota. In fact, the B. fragilis group, 25 species like B. the Tautomicron, B. vulgatus, it's among the most frequently isolated anaerobes from clinical infections globally. Knowing the source gives you a huge head start.
Can we break down the common culprits by their microscopic look, gram stain, and shape? That helps
Sure.
with initial ID, right?
Yes, definitely. Categorizing by gram stain and morphology is very useful early on, especially if culture results aren't back yet. Most significant anaerobes fall into a few key groups. Anaerobic gram-negative bacilli, rod-shaped, stained red-pink. Key genera, Prevotella, Bacteroids, Fusobacterium, Porphyromonas. Very common, wide range of infections.
Okay, rods, gram-negative.
Anaerobic gram-negative Kochi, spherical, stained red-pink. Veillonella species are notable here. Anaerobic gram-positive Kochi, spherical, stained purple-blue. The main pathogens are the Peptostreptococcus, like P. micros, Phanegolia magnus.
Got it, gram-positive Kochi.
Anaerobic spore-forming gram-positive rods. Rod-shaped, purple-blue, form-resistant spores. Clostridium species are the big ones here. Think tetanus, botulism, C. diff. Anaerobic non-spore-forming gram-positive bacilli. Rod-shaped, purple-blue, no spores. Examples: Ketobacterium acnes, skin bug, foreign body infections, and Actinomyces species, chronic granulomatous infections. Understanding these categories helps narrow things down when you look at a gram stain, a vital early clue.
So once these organisms breach a sterile site, what's their secret sauce for causing infection? What conditions do they need, and what are their virulence factors, the weapons in their arsenal?
Right, their pathogenicity relies on precise environmental conditions plus their specialized tools. First, they need that anaerobic environment. Low oxidation reduction potential, very little oxygen. This can happen directly from tissue ischemia, loss of blood flow trauma, surgery creating pockets, or perforated viscus like a ruptured bowel.
Creates the right conditions.
Yes, but more often it's a polymicrobial infection. Here, facultative organisms, the ones that can use oxygen, play a crucial role. They consume remaining oxygen, maintaining that low potential for the obligate anaerobes. Once established, they face host defenses. That's where virulence factors come in. Similar to aerobic pathogens, they use molecular tools to evade defenses, stick to surfaces, produce toxins and enzymes, or display surface structures like capsules and LPS that help cause disease. Masters of adaptation in these low oxygen zones.
Can you give us some examples of these virulence factors? What makes them so effective at causing damage?
Certainly. They're fascinating adaptations. Adherence is often step one. Oral species like Porphyromonas gingivalis use fimbriae, little hair-like things to attach. Fusobacterium nucleatum acts as a bridge, binding to almost all other oral bacteria, forming dental plaques. Bacteroides fragilis uses pili, fimbriae, hemagglutinins for gut attachment.
Sticking is key.
Absolutely. Many also produce exoproteins. P. gingivalis makes collagenase, breaking down tissue. Clostridial species are infamous for potent exotoxins, botulinum, tetanus, C. diff toxins. Interestingly, the lipid A molecules, endotoxins, of anaerobic gram-negatives like B. fragilis are way less potent, 100 to 1,000 times less active than those for aerobic gram-negatives.
Less potent. Why is that important?
It helps explain why severe systemic reactions like disseminated intravascular coagulation, DIC, that widespread clotting and bleeding are much less common in anaerobic gram-negative bacteremia. The lipopolysaccharide from Fusobacterium is an exception, though. It's more potent and contributes to the severity of Lemierre syndrome.
Ah, okay. Now, the source material really highlights the capsular polysaccharide complex of B. fragilis. What makes that one so special? Sounds like a game changer for B. fragilis.
It really is a key insight, a fascinating specialized virulence factor. Remember, B. fragilis is a tiny fraction of our normal gut bugs, but it's the anaerobe most often isolated from serious infections, especially intra-abdominal infections and bacteremia. Its knack for causing disease, particularly forming abscesses, is largely down to its capsular polysaccharide complex.
Capsule is the main weapon.
In animal models, yes, it was identified as the major virulence factor for inducing abscesses. What's unique is B. fragilis makes at least 8 distinct capsular polysaccharides, way more than most bacteria. And even more remarkably, it can switch which ones it displays using on-off gene regulation, rapidly changing its surface.
Clever disguise.
Very. But here's the truly special part. 2 of these, polysaccharide A, PSA, and polysaccharide B, PSB, have unique zwitterionic charge motifs, both positive and negative charges in the same unit. Rare stuff for bacterial polysaccharides, and it's this zwitterionic structure that lets PSA induce abscesses.
How does that work?
PSA stimulates host macrophages to release pro-inflammatory cytokines IL-8, IL-17, TNF-A via toll-like receptor 2. This cytokine flood draws in polymorphonuclear neutrophils, PMNs, a type of white blood cell, to the peritoneum. Once there, the PMNs stick to mesothelial cells, which have been prompted by TNF-A to put out more adhesion molecules. The sticking of PMNs in mesothelial cells is thought to form the crucial nidus, the core, for the abscess.
So B. fragilis is basically tricking our immune system into building a protective wall for it.
That's a great way to put it. It's actively manipulating our defenses to create its own walled fortress, a very sophisticated way to drive pathology.
It really sounds like these infections are a team effort, like you said, a synergy between different bacteria. How does that play out clinically? Why is understanding that synergy important?
You're absolutely right. Team effort is perfect. Clinically, anaerobic infections are almost always polymicrobial. Typically 3 to 6 different organisms from an infected site. This isn't random. It's a powerful synergistic pathogenesis. Different species cooperate to boost the infection and beat host defenses. This cooperation happens in several ways. 1. Creating the right environment. Facultative organisms act as oxygen scavengers, creating the low oxygen potential the obligate anaerobes need. Without this conditioning, many couldn't survive.
The facultatives pave the way.
Exactly. 2. Inhibiting host defenses. Anaerobes themselves interfere. They produce byproducts like short-chain fatty acids and succinic acid, which inhibit phagocytes, the immune cells that eat bacteria, from clearing even the facultative partners. Creates a permissive zone. 3. Providing growth factors. One bug might make nutrients another needs, like oral diphtheroids making vitamin K for P. melanogenica. 4. Creating tissue damage. The combined activities cause more damage than one species alone, further lowering oxygen and promoting spread.
So they all help each other out.
Precisely. All these mechanisms, working together, powerfully potentiate abscess formation. So the key insight for clinicians, these aren't about a single bad actor, it's a bacterial ecosystem. Even the oxygen users are vital for the anaerobes. You have to disrupt the whole system.
Okay, so for you, the listener, maybe trying to piece together a complex clinical picture, what are those undeniable red flags, the things that scream anaerobic infection to an experienced clinician?
Understanding these clues is absolutely paramount, especially since direct culture diagnosis can be tricky. A physician looks for several crucial points. 1. Proximity to mucosal sites and barrier breach. If an infection pops up near a site loaded with anaerobes, mouth, gut, female genital tract, and there's been a breach in that barrier, that's a huge clue.
Location, location, location. Plus a broken fence.
Exactly. 2. Favorable conditions. Look for signs of lowered oxidation reduction potential. Trauma, tissue destruction, compromised blood supply, ischemia, necrosis. These are oxygen poor zones where anaerobes love to grow. 3. Polymicrobial nature. Remember, rarely single organisms, often a complex mix, sometimes over 10 species. That synergistic team is a hallmark.
The bacterial gang again.
Right.
Yeah.
4. Abscesses and necrotic tissue. Anaerobes thrive in abscess cavities or dead tissue. A critical clue is an abscess yielding no growth on routine culture, but the Gram stain shows teeming bacteria, often called sterile pus. Any deep tissue abscess raises suspicion.
Sterile pus, but full of bacteria on the stain.
Okay.
5.
Gas in tissues. Not diagnostic alone, but the common and deep anaerobic infections. You might feel crepitus, that crackling under the skin. 6. Putrid odor. The classic foul-smelling discharge from volatile fatty acids. Diagnostic when present, but often a lead sign, maybe only in 30–50% of cases. Its absence doesn't rule out anaerobes.
Don't rely on the smell alone then.
Correct. 7. Targeted therapy success. Interestingly, you can sometimes cure these synergistic infections by targeting only some organisms. Knock out key partners, especially the facultators creating the environment, and the whole interdependence collapses. 8. Less severe systemic response. Unlike severe aerobic gram-negative infections, septic shock and DIC are unusual in purely anaerobic infections. Again, likely due to their less potent endotoxins.
Okay, those are great clinical clues. But beyond observations, how do we actually confirm it in the lab? And what are the challenges there?
Laboratory diagnosis has distinct challenges. It needs 3 critical steps: meticulous sampling, avoid contamination, selecting appropriate specimens, and proper handling by the lab. The absolute golden rule: do not use samples from normally colonized sites for anaerobic culture if you're diagnosing an infection in a sterile area. So specimens from the mouth, nose, vagina, feces generally unacceptable for identifying a pathogen. The normal bugs will overwhelm the results.
Makes sense. So where do you sample from?
Use samples from normally sterile locations: blood, pleural fluid, peritoneal fluid, CSF, tissue biopsies from the infected site. Liquid or tissue specimens are better because they preserve the anaerobic environment. Collect in air-free syringes or anaerobic transport bottles. Transport immediately.
Get it there fast. Keep the air out.
Exactly. But because it's difficult and slow, some take days or weeks to grow. Diagnosis often relies on presumptive evidence, using those clinical clues. If cultures from an obviously infected site show no growth or just one aerobic species, but the Gram stain shows mixed bacteria, strongly suspect anaerobes. Suggest bad transport or culture technique. Also, prior antibiotic therapy massively reduces their cultivability. False negatives are common. And finally, if an infection fails to respond to antibiotics not active against anaerobes like aminoglycosides, that strongly points to an anaerobic cause.
Given all those diagnostic hurdles, it must be pretty hard to get precise numbers on how often these infections actually happen.
Right. You're absolutely right. It is very challenging to get precise, accurate data on the true incidence or prevalence. Directly because of those diagnostic difficulties we just talked about, the culture complexities, contamination risk, lack of reliable techniques in many labs, many anaerobes are just really finicky and oxygen sensitive.
Hard to count them accurately.
Very. But despite that, we absolutely know anaerobic infections are frequently encountered clinically. Looking at data we do have from surgical specimens, anaerobes make up a significant 7–8% of all bacteria isolated. Even more pronounced in abscesses, they account for 13–15% of isolates there. And while they're less than 1% of all bacteremia cases anaerobes in the blood, those cases are particularly important because they can be severe. So, exact figures are elusive, but their clinical impact is undeniable.
Okay, so they're common enough. Where in the body do we most often find them when they do cause infection?
Right. Based on studies looking at where cultured anaerobes come from, they're most commonly isolated from infections in specific regions. The most prevalent types are consistently found in the head and neck, then closely followed by the lung, the abdomen, and soft tissue and joints. Other significant sites, maybe slightly less frequent, include bacteremia, catheter-related infections, and surgical site infections. This distribution largely mirrors where the normal anaerobic microbiota lives and the common ways they cause disease, often via that breach in mucosal barriers.
Okay, let's zoom in now. Let's go through the body and see how these infections actually show up in different areas. Are there common hallmarks across all sites we should keep front of mind?
Yes, before we dive into specifics, always remember these universal hallmarks for anaerobic infections wherever they pop up. Access formation, putrid purulence, a foul pus, septic thrombophlebitis, infected clotted vein, tissue necrosis, tissue death, and that key point, failure to respond to broad-spectrum antibiotics that lack anaerobic coverage. These clues are often your best guideposts.
Got it. Abscess, bad smell, dead tissue, tricky veins, and doesn't respond to some common antibiotics. Okay, starting at the top. Mouth, head, neck, teeming with anaerobes. What kind of trouble can they cause there?
Oh, major trouble. The mouth, head, and neck are prime territory. Anaerobes are consistently involved in a wide array of infections there, usually originating from the upper airway microbiota. A particularly severe example is Ludwig's angina. This is a rapidly spreading cellulitis of the floor of the mouth, often starting from a bad dental abscess, especially second or third molars.
Ludwig's angina sounds serious.
It is. Marked swelling, pain, trismus difficulty opening the mouth, and the tongue gets pushed up and back. It can block the airway, life-threatening, sometimes needs an emergency tracheotomy. Another severe one is Lemierre syndrome, usually caused by Fusobacterium necrophorum. Starts as a sore throat that invades the lateral pharyngeal space. Leads to septic thrombophlebitis of the internal jugular vein, and often septic emboli, bits of infected clot, travel to the lungs most commonly. These are high-stakes infections where anaerobes drive the severity.
Wow. Okay, from the head, let's move into the brain. Do anaerobes cause CNS infections? What does that look like?
Yes, there are significant players in CNS infections, especially brain abscesses recovered in up to 30% of cases. Also found in epidural abscesses, subdural MPMs. Brain abscesses often result from spread from nearby infections, ear, autogenic, tooth, odontogenic, or sinuses. So the bugs reflect those primary sites. Frontal lobe abscesses often linked to sinusitis anaerobes, strep, staph. Obligate anaerobes rarely cause meningitis itself, maybe partly because CSF isn't routinely cultured for them.
Right, the culture issue again. Now, the lungs seems like the last place anaerobes would thrive, right? All that oxygen. How do they get a foothold?
It seems counterintuitive, doesn't it?
Mm-hmm.
But the lungs are constantly seeded by oral bugs through microaspiration. We all do it a little bit. In people with impaired clearance, bad cough reflex, maybe alcohol intoxication, or increased aspiration neurologic issues, these anaerobes can set up shop. Anaerobic lung infections tend to have an indolent, a slow course, develop over days or weeks.
So slower onset. What kinds of infections?
Aspiration pneumonia develops over days, weeks. Often in people with those risk factors, maybe bad dental health too. Sputum might not smell bad initially. X-rays show consolidation-independent lung segments, the parts gravity pulls stuff into. And crucially, expectorated sputum. Unreliable for anaerobic culture. Too much mouth contamination. Eat specialized techniques like protected brush or BAL.
Heat special sampling. What about lung abscesses?
Anaerobic lung abscesses result from that subacute infection. Patients have constitutional symptoms, malaise, weight loss, fever, night sweats, foul-smelling sputum for maybe 1-3 weeks. Often have a prior dental infection, almost always polymicrobial. Clinical improvement usually requires hitting those anaerobes with antibiotics.
And empyema, you mentioned that.
Empyema is a later stage, long-standing anaerobic lung infection. Thick, purulent gunk in the pleural space, the space around the lung. Often with a bronchopleural fistula, an abnormal tunnel between the airway and that space. Presents with foul sputum, pleuritic chest pain, really tender chest wall. It's different from just fluid buildup. Empyema has thick, foul pus, super high white cell count, high LDH, low pH loculations compartments, and a thick peel on imaging. Needs drainage, sometimes surgery to remove the peel, decortication. Takes months to resolve sometimes.
Okay, moving down into the abdomen. What happens when the gut's defenses are breached?
Right, in the abdomen, any breach in the gut lining, trauma, perforation, malignancy, lets that dense gut microbiota escape into the sterile peritoneum. The specific bugs reflect where the breach is. Perforated appendix, you'll almost always find E. coli and the B. fragilis group, plus other colonic anaerobes. Intra-abdominal infections are often incredibly polymicrobial. Average of 10 different species, anaerobe to aerobe ratio around 3.1.
A real soup of bacteria. You also mentioned typhlitis, associated with neutropenia.
Yes, neutropenic enterocolitis, or typhlitis. Seen in patients with neutropenia, very low white cells, often after chemo. Marked thickening of the bowel wall, usually the cecum, part of the large intestine. Patients have abdominal pain, fever, often get bacteremia with gut bugs from that segment. Finding Clostridium septicum bacteremia is particularly ominous, highly associated with underlying cancer, especially colon cancer.
Wow, a specific bug linked to cancer. Okay, shifting to pelvic infections. How common are anaerobes there? Anything unique?
Very common in pelvic infections. Makes sense given the rich anaerobic microbiota of the female genital tract. Think pelvic inflammatory disease, PID, pelvic abscess, endometritis, tubal ovarian abscess, septic abortion, post-op or postpartum infections. Often mixed infections with anaerobes and coliforms, but pure anaerobic infections happen more often here than in the abdomen. Key players, Pegotella bivia, P. diciens, the B. fragilis group, and bacterial vaginosis, BV, super common. Not exactly an infection, more a syndrome. Big shift in vaginal ecology away from lactobacillus towards an overgrowth of various anaerobes, Gardnerella, Peptostreptococci, Prevotella mobiluncus, causes that profuse, often fishy-smelling discharge.
Okay, and skin and soft tissue infections. These can range from pretty minor to terrifyingly serious.
Absolutely.
Yeah.
Any skin or soft tissue injury trauma, ischemia, poor blood flow, surgery creates that ideal anaerobic environment. Bacteria get in directly, intestinal surgery, bed sores, hemobites, or spread from nearby rectal abscesses. Anaerobes are very common in diabetic foot ulcers. Deep soft tissue infections involving anaerobes are particularly nasty. Gas gangrene, crepitus cellulitis, mostly Clostridium perfringens. Extensive gas in tissue feel the crepitus, that crackling. Thin, dark, sometimes foul discharge. True gas gangrene is rapid, severe.
Gas gangrene. That sounds bad.
It is. Progressive bacterial synergistic gangrene, Mullany gangrene, exquisite pain, redness, swelling, then ulceration with a purplish ring, localized pain, usually no fever. Peptostreptococci, microaerophilic strep often involved. Synergistic necrotizing cellulitis affects deep fascia, pain, fever, systemic symptoms. Fournier gangrene is this type hitting the scrotum, perineum, abdominal wall. Polymicrobial S. aureus, B. fragilis group, Pepto, Clostridium, fusobacteria.
Soignes, yeah, that's a surgical emergency.
Absolutely. Necrotizing fasciitis, rapidly spreading destruction of fascia, often polymicrobial with anaerobes and aerobes. Presents with skin breakdown, gangrene, fever, subcutaneous gas, anesthesia, numbness before skin death, foul discharge. The foul smell and gas are big clues for anaerobes.
Okay, so bones and joints, do anaerobes get in there too?
They do. For bone infections, osteomyelitis, actinomyces species are the most common culprits, especially the jaw cervicofacial actinomycosis, lumpy jaw. These are chronic, form-draining sinus tracts, cross-tissue boundaries, need long treatment. Other anaerobes usually spread from nearby infections like diabetic foot ulcers. Hematogenous spread via blood to bone is rare for anaerobes. Anaerobic arthritis, though, is uncommon, usually one bug, typically from hematogen spread. Historically, Fusobacterium, now more C. acnes, Peptostreptococci, B. fragilis.
Right. Finally, bacteremia anaerobes in the blood. What's the main player and how serious is it?
When you find anaerobes in blood cultures, Bacteroides fragilis is, hands down, the most common isolate, and its frequency is actually increasing, likely due to more elderly, immunocompromised patients or those on meds that disrupt mucosal barriers. The source is usually an abscess abdomen, female genital tract, soft tissue.
So it means there's an abscess somewhere.
Almost always indicates an underlying infection focus, yes. Now, clinically, B. fragilis bacteremia rigors, hectic fevers, can look like aerobic gram-negative bacteremia. But crucially, the incidence of septic shock is lower with B. fragilis, again thought to be due to their less potent endotoxins. But don't let that fool you. Isolating any B. fragilis group member from blood is very serious. Untreated, it's associated with a high mortality rate, 60%.
60%, that's incredibly high.
It is. Factors increasing mortality.
Right.
Older age, over 66% mortality of 60. Isolating multiple species, and critically, failure to surgically remove the focus of infection. Source control is paramount.
Okay, so what does this all mean for treatment? How do we tackle these complex, often mixed, sometimes hidden infections? It sounds like it's not just about picking an antibiotic.
You're absolutely right. Successful therapy for anaerobic infections is definitely multifaceted. It's never just about antibiotics alone. A comprehensive approach is crucial. Typically involves three key pillars. 1. Appropriate antibiotics, chosen carefully to cover the likely suspects. 2. Surgical debridement, removing any dead or devitalized tissue. This is critical. Antibiotics struggle to get into dead tissue. 3. Drainage of large abscesses. Abscesses are walled off. Draining removes the bacteria and helps antibiotics work better.
So drugs, surgery to clean up, and drainage.
Exactly. Plus, if there was a breach perforated bowel, deep wound that needs to be closed promptly to stop ongoing contamination, ignore any of these and treatment can fail or relapse.
Okay, let's dig into the antibiotics. This seems tricky, especially with resistance. What are the general rules for choosing? And why is susceptibility testing sometimes skipped?
Yeah, antibiotic selection is nuanced. Because many are polymicrobial aerobes and anaerobes, the drugs must be active against both categories. Empirical selection choosing before lab results is based on the infection's location, suggests likely bugs, severity, local resistance patterns, and drug factors like penetration, for example, into the brain. The general rule is use the narrowest spectrum agent possible. Minimize collateral damage to normal bugs, reduce resistance pressure.
Right. Don't use a sledgehammer if a tack hammer will do.
Precisely. Now, susceptibility testing for anaerobes. It's limited in routine labs. They grow slowly. Methods aren't perfectly standardized, and often empirical choices work well. However, it's vitally important for serious infections, brain abscess, endocarditis, or when a patient isn't responding. Could be a resistant strain. Monitoring resistance patterns is also critical for public health.
Makes sense. So what are the big no-nos for antibiotics against anaerobes? And what are the main go-to options?
Knowing what doesn't work is key. Antibiotics with no useful activity against anaerobes, generally avoid these. Aminoglycosides, monobactams, and trimethoprim sulfamethoxazole, they just don't cover most relevant anaerobes.
Okay, aminoglycosides, monobactams, TMP, SMX out. What is in?
With the caveat that resistance patterns change, the antibiotics commonly used empirically against anaerobes, the main go-to options include metronidazole, lactamide inhibitor combinations like augmentin, zosyn, clindamycin, carbapenems like meropenem and mepenem, and chloramphenicol. These are the core arsenal, but each has strengths and weaknesses, especially with resistance.
Can you give us a quick rundown? Strengths, weaknesses, resistance issues for each. That's crucial for making smart choices.
Absolutely. Understanding the nuances is key. 1. Metronidazole. Strengths. A powerhouse against most gram-negative anaerobes, nearly all bacteroids, and gram-positive spore formers, Clostridium. Weaknesses, resistance. Clinically unreliable against gram-positive non-spore formers like actinomyces, many Peptostreptococcus. Resistance is creeping up in some areas, even in bugs like Fusobacterium and Prevotella.
So good, but not perfect, especially for some gram-positives.
Right. 2. The lactamolactamase inhibitor combinations. Higi ampicillin sulbactam, piperidecilin tazobactam. Strengths. Overcome the lactamase enzymes made by most B. fragilis group isolates, generally effective against many anaerobes. Weaknesses, resistance. Resistance to some, like ampicillin sulbactam, is increasing. And be careful, many newer cephalosporin inhibitor combos have limited anaerobic activity.
Okay, need to check which specific combo.
Yes. 3. Clindamycin. Strengths. Active against many anaerobes, historically a workhorse. Weaknesses, resistance. Major concern here. Resistance in bacteroid species shot up significantly in the U.S. from 7% in 81 to 33% by 2012. Globally can exceed 80%, makes it unreliable for many serious anaerobic infections now.
Wow, Clinder resistance is a big problem.
Huge. 4. Carbapenems. Meropenem, imipenem, ertapenem, dorpenem. Strengths. Highly active. Less than 3% of bacteroids isolates resistant. Imipenem often has the lowest resistance rate. Broad coverage. Weaknesses, resistance. Generally excellent but rare carbapenems producing B. fragilis have emerged, usually reserved for more serious infections.
The big guns.
Pretty much. 5. Chloramphenicol. Strengths. Resistance rare in bacteroids, excellent in vitro activity against basically all relevant anaerobes. Weaknesses, resistance. Some clinical failures seen despite lab susceptibility. Concerns about bone marrow toxicity limit its use if safer options exist.
Okay, good coverage, but potential toxicity. Finally, tailoring treatment to the site. You mentioned it above versus below the diaphragm. How does that guide choices?
That distinction is incredibly useful clinically because the main bugs, and thus the empirical regimens, differ significantly. Infections above the diaphragm. These usually reflect the orodental microbiota. Need to cover both aerobic and anaerobic bugs. Since 70% involve lactamase producers, penicillin or cephalosporin alone often fails. Recommended options. Clindamycin, if local resistance isn't high, a lactamolactamase inhibitor combo, or metronidazole plus a drug for strep, like penicillin.
Okay, cover mouth bugs, watch for resistance.
Exactly. Anaerobic infections below the diaphragm need agents specifically active against bacteroid species, including B. fragilis, suitable single agents, cefoxitin, moxifloxacin, apolilactamide lactamase inhibitor combo, or a carbapenem. Alternatively, a 2-drug regimen, one for anaerobes, one for coliforms. Example, metronidazole plus a cephalosporin or fluoroquinolone. Add ampicillin or vancomycin if you suspect enterococci. Importantly, due to rising resistance, clindamycin and cefodin are no longer recommended for empirical intra-abdominal infections, nor is ampicillin sulbactam due to high E. coli resistance.
Wow, so guidelines have changed for below the diaphragm.
Significantly.
Yeah.
For CNS infections, treat with metronidazole, a carbapenem, or chloramphenicol. Penicillin if only gram-positive anaerobes. Do not use clindamycin or cefoxitin, poor CSF penetration. osteomyelitis and arthritis. Cover aerobes and anaerobes of polymicrobial. Arthritis treatment duration similar to aerobic cases. And the why matters. Studies on Bacteroides bacteremia clearly show patients getting effective therapy have lower mortality and clear their blood cultures faster. Targeted therapy saves lives.
That really drives home the importance of getting it right. What if therapy fails or the infection comes back? What's the reassessment process?
Great question. When an anaerobic infection fails to respond or relapses, it demands a thorough reassessment. Several potential causes need checking. First, they're an uncontrolled source of infection. An ongoing leak, a pocket mist. Need more imaging, CT, MRI, to see if more surgical drainage or debridement is needed. Source control is often the most critical step.
Gotta find and fix the source.
Absolutely. Second, could it be superinfection with a new organism? Initial antibiotics worked, but a new resistant bug moved in. Third, and increasingly relevant, antibiotic failure, wrong drug or resistance developed. This is why getting new culture specimens from the site is essential. These new samples help identify resistant bugs, and you should strongly consider getting susceptibility testing on those isolates. This testing, while sometimes tricky, becomes invaluable when empiric therapy fails. It gives precise guidance, so it's a comprehensive reevaluation. Clinical picture, imaging, updated microbiology, that's the path to figuring out the problem and adjusting the strategy. #tag outro.
What an incredible journey through the world of anaerobes. Seriously, from Leeuwenhoek's early revolutionary observations to the complex biology, their crucial roles in health, and the intricate ways they cause disease and how we fight back. We've gone from principles to granular details of specific infections and treatments. It truly highlights how much of our inner world is shaped by these oxygen-averse organisms. I really hope you feel, truly empowered with this depth of knowledge.
This deep dive really does underscore a critical point. Knowledge is most valuable when it's understood and applied. That intricate balance of our microbiota is so essential. And understanding how it gets disrupted or how these organisms act as silent pathogens, it's key. It reminds us there's always more to learn. Even the smallest, most hidden organisms have profound implications, constantly challenging us to refine our critical thinking and approach. It really is about achieving true mastery of these complex concepts.
So the next time you think about bacteria, take a moment to consider those that shy away from oxygen. They might just be the most fascinating and impactful players of all. Keep that curiosity alive. Keep digging deeper into the amazing world around and within you. Thank you for joining us on this deep dive. Until next time, stay well informed.